Okay, so I'm gonna introduce Dr. Kolarik. Is that right? Okay. Her pronouns are she, her. She's a primary care physician currently practicing in Knoxville, Tennessee. She studied medicine at the ETSU Quillen College of Medicine in Johnson City, Tennessee, and completed her residency in family medicine at the University of Tennessee Medical Center in Knoxville, Tennessee, where she was chief resident. She now practices at Cherokee Health Systems, providing full spectrum primary care to all ages and all stages of life. Particular interests include LGBTQ care, especially HRT for transgender patients, chronic disease management, women's health, and adolescent medicine. Dr. Kolarik spends her time outside of the office singing in an all-physician rock band. Awesome. Playing board games with her husband and spoiling her 7-pound Yorkie. Welcome to Dr. Kolarik.
Hello, thank you so much. I appreciate that. Well, I'm so excited to be here today. I'm so thrilled to see how many people are here on a Saturday afternoon to learn more about this topic that I'm so excited to speak about. Give me just a moment. I'm going to work on getting my PowerPoint up here. All right. So today I'm going to be talking about primary care for the transgender and gender diverse person. Again, I'm a primary care doc at Cherokee Health. We're a federally qualified health center, an integrated health center where we have primary care, behavioral health, and many other resources for our patients. And my pronouns are she, her. So I have a few objectives today. One is that we'll be able to identify a patient who meets the criteria for medical treatment of gender dysphoria, understand what types of physicians and other medical providers are offering gender affirming care, have a basic understanding of the medications used for hormone replacement therapy or HRT, have a basic understanding of the non-medical gender affirming interventions that may be sought by a gender diverse patient, and finally understand preventative health screenings and how those apply to the gender diverse person. Sort of my two main goals today. I know that we're sort of a split between mental health providers and then physicians or other providers who may be prescribing these medications. So I kind of tried to split the difference. My goals are to empower any prescribers or physicians that may be here to offer this kind of care, and as well to sort of, for our mental health folks that are here, to give them a better idea of the medical interventions that their patients may undergo with their physician. I don't have any significant disclosures. I should say that I am very passionate about gender affirming care, and gender affirming care is a part of primary care in particular. So you may notice that bias within my presentation today. So starting from the beginning, who meets the criteria for the medical treatment of gender dysphoria? This has already been hit on a couple of times today, but just to sort of recap, at first we sort of need to describe gender dysphoria. So this term first, or it's a DSM-5 diagnosis, but it actually first appeared in the DSM-3 in 1980. This is the term that we use in healthcare as a diagnosis because, of course, being transgender is not a pathology. It's not a disease. So this is what we use as the thing that we're treating when we're using gender affirming care. It's defined as a discomfort arising in some individuals from incongruence between their gender identity and their sexual anatomy at birth. The major criteria are persistent incongruence between gender identity and external anatomy at birth, as well as the absence of confounding mental disorders. So these are the main criteria that I pulled from those WPATH guidelines that we've already talked so much about today. The first one is persistent, well-documented gender dysphoria. The question that I always get with this criteria is, what does well-documented mean? This doesn't mean that you've been seeing this patient for years and you've been documenting in your charts for a very long time this gender dysphoria. I mean, this is more to mean that this patient has been experiencing this, and then I document it well in my chart, this patient's persistent experience of gender dysphoria. Of course, with every medical treatment, we want to make sure our patient has the capacity to make a well-informed decision. And finally, relevant medical or mental health issues are well controlled. This is another one that I get asked a lot of questions about because I think this well controlled can sometimes, we don't really know exactly what that means. I don't need someone to walk into my office as the picture of health, never had a bad day in their life, never had a medical condition, never been sad, depressed, down, anxious, any of that stuff. I certainly don't expect that from any patient, regardless of why they may come into my office. What I do need is that the patient's general mental health issues and their medical issues are stable and undergoing treatment if treatment is necessary. So what types of physicians or medical providers offer gender affirming care? This infographic I actually pulled from hormone.org, which is run by the Endocrine Society. And I thought it was a pretty great representation of all the medical folks that may be involved in a patient's care. As I mentioned, it's from the Endocrine Society. I actually don't love the primary care designation, where half of what we do is navigating insurance coverage and providing referrals to specialists. But otherwise, I think it's a really good representation. So of course, primary care providers are providing general medical care, chronic disease management, and some, and hopefully in the future, many primary care providers will be providing hormone therapy, therapy for gender dysphoria. We of course have our behavioral health colleagues who will be involved. Gynecologists, urologists, and reproductive endocrinologists will be involved in terms of gender affirming surgeries, discussing fertility, pelvic health. We'll have plastic surgeons who are involved for gender affirming surgeries. Dermatologists who will address hair loss or unwanted hair or any skin changes that may occur related to hormone therapy. And finally, endocrinologists or pediatric endocrinologists will certainly be available and be familiar with this care. Though in most cases, I think that specialist care is not necessarily warranted for the standard patient. So let's talk HRT. So before I kind of get going on this, I am using the term HRT in this presentation. We're starting to see the term GAHT, or gender affirming hormone therapy, used more and more. As of right now, most of my patients are still using the term HRT, and when they call my office and ask for an appointment, they're asking for an appointment for HRT. So for the purpose of this talk, that's what I've used, though you may see these terms used interchangeably. The other thing I want to certainly address is the terms masculinizing and feminizing that I'll be using throughout this presentation. Obviously, we know that this gender binary comes with its own sort of pitfalls and problematic issues. But in terms of this particular treatment, I'll be using those terms. Obviously, we know that people fall all over that spectrum between masculinizing and feminizing, and there are people who don't identify as being on that spectrum at all. I don't mean to exclude those folks from this talk. This just was sort of the easiest way to divide it up for these purposes. So HRT, partially irreversible. It's treatment to facilitate the development of secondary sex characteristics of the experienced gender of the patient. This has been said several times today, but I'll say it again. Not all gender diverse persons require or seek hormone treatment, and their identity as a transgender person is not related to whether they're on hormones or seek any other specific care for themselves. Those who do receive treatment generally report improved quality of life and self-esteem. There's two key hormones that we're working with, estrogen and testosterone. And again, this was one we've discussed quite a bit today, but essentially we're entering the patient into a second puberty. And so it's important to note that just like the first puberty they may have gone through, this takes years to take full effect. I know a lot of my patients are often in a hurry for the changes they're looking for, but we do have to remember that these take some time. Most of the medications that we're using for HRT, primary care docs are already using to treat other conditions in their cis patients. We use them to treat menopause, we use them for contraception, to treat hirsutism, which is abnormal hair growth, abnormal uterine bleeding, and many other medical issues. So these are not unfamiliar medications at all. So those two sex hormones that we were talking about, the first is estrogen, which is one of the two main sex hormones in cis women, the other one being progesterone. It helps bring about that physical change that we see in female puberty. We have three main types: estradiol, which is the most common estrogen that we see in women of reproductive age; estriol, which is the most common estrogen of pregnancy; and estrone, which is the most common estrogen of postmenopausal cis women. Testosterone, again, the main sex hormone that we see in cis men. Same thing, brings about those changes in male puberty. Levels are highest in cis men around age 20, then slowly decrease from age 30 to 35 and on. You'll also see the word androgen used some during this presentation. That's just another word that we use for the male sex hormone. So we're going to start out with feminizing therapy. The goals of this are to reduce the level of testosterone, as well as to provide enough estrogen to allow the feminizing changes that our patients are looking for to occur. The main medications that we'll see used are estradiol. This does two things. One, it does help reduce testosterone levels, and it promotes feminine physical changes. You'll then see medications that are referred to as testosterone blockers. This helps assist in the lowering of the testosterone levels without us having to be so aggressive with high levels of estrogen. Most commonly, the medication that we'll see used is spironolactone, though there are a couple of other ones that we'll talk about. Finally, you will hear about progestogens. These are studies are still sort of back and forth on whether this is useful during HRT. Anecdotally, it does show some improved breast development, and some of my patients do request it and do use it. So for feminizing therapy, the physical changes that we can expect within the first 1 to 3 months, we will see some decrease in sexual desire and function, including erections, as we see that testosterone levels start to fall. We may notice some slowing of baldness if that's affecting patients, and that may even reverse slightly. After 3 to 6 months, we'll start seeing softer skin, a decrease in the testicular size, as well as increase in breast development and tenderness, as well as change in body fat distribution. And what we're talking about is body fat will start to distribute itself in that more, what we would consider phenotypical feminine distribution, more into the hips and thighs. Finally, at 6 to 12 months, we'll start to notice softening of hair, as well as becoming finer. So I put this slide in here not so much to go over the exact dosing of estrogen, but just to talk about sort of the multiple formulations that your patients may be on. So first of all, there's the oral or sublingual estradiol. That's what most of my patients end up being on. There is transdermal, which is a patch formulation of estrogen. Many of my patients do like that. Although as we get to some higher doses of estrogen, the maximum dose of a patch is 100 micrograms. So patients will end up having sort of 4 patches on their body, which can be a little much for someone to manage. Plus, some folks have difficulties sticking it to their skin. So certainly a great option if that's what our patients prefer. And then we have intramuscular formulations of estrogen. These are injections. They do work very well, but they do have a little bit more, as you can imagine, if you're doing an injection every 2 weeks, you have a little bit more peak hormone and then a little bit more of a trough, and so on and so forth. These are our androgen blockers, spironolactone again being our most commonly used, but finasteride also is used fairly commonly. So in terms of what kind of laboratory monitoring may be necessary for these patients, at a baseline, we want to get renal function as well as potassium electrolyte levels if our patient is going to be using spironolactone. Spironolactone can increase potassium levels, so that's one we watch out for. The big hormones that we use for monitoring our dosing are estradiol levels and total testosterone levels. There's really no reason to monitor lipids or blood sugar more frequently than you would based on regular primary care guidelines. And then in prolactin levels, only if you're having concerns for symptoms of prolactinoma in your patient would that be necessary. So this is taken from the informed consent that I use in my office. And it's important with our patients to understand what changes we're thinking will be permanent versus the ones that will likely not be permanent should they stop the therapy. So in terms of feminizing therapy, the permanent changes would be that breast growth and development, as well as the shrinking and softening of testicles, as well as potentially testicles producing less sperm. We'll talk more about fertility issues later in this presentation. The ones that we would expect to reverse if for some reason the hormone therapy was stopped is the loss of muscle mass and decreased strength, any weight gain that may have occurred, the skin changes will go back, as well as changing of the facial and body hair, changes in baldness, changes in sex drive. And then any changes in mood that may have occurred during treatment will also revert if the hormone therapy is stopped. So some special considerations with these patients. So for those who are not sort of familiar with this risk, every time that we use estrogen, whether it's in a trans patient versus a cis female who may be undergoing hormone therapy after menopause, there is a risk of VTE, which is venous thromboembolism. That's blood clots, essentially. It's the same thing, for instance, when we start a cis female on an oral birth control pill that contains estrogen, there's this increased risk of blood clot. So tobacco abuse, of course, also increases your risk of VTE. So it's important that at every visit, you're counseling your patient on cessation of smoking and ways that we can support them in this. That's certainly also a way that mental health folks can sort of support their patients if they are smoking and using estrogen, seeing how we can help them stop smoking. However, I would not consider this an absolute contraindication to treatment with estrogen. I would not want to withhold a life-saving medication just because my patient is smoking. Quitting smoking is really, really hard. And we just want to support our patients through that. One thing you can consider is using the transdermal or the patch estrogen because it is associated with slightly lower risk of that VTE. For the loss of erectile function that our patients may consider or may experience, we could consider prescribing sildenafil or tadalafil. Those are Viagra and Cialis. Those can certainly help our patients maintain their sex lives during this treatment. You can also consider decreasing their spironolactone or their androgen blocker dose to allow that testosterone level to come back up just a little bit. That may sometimes be enough to address this issue. Now, if you have a patient that has a history of VTE, or for some reason we think may have an increased risk at baseline of VTE, this is something that really just needs to be considered on a case-by-case basis. And considering what that increased risk is, we may make different decisions about their care. For instance, someone who had a history of a blood clot because they had surgery and were in bed for 12 weeks and got a blood clot, that's a very different situation than someone who we think may actually have a clotting disorder that's putting them at a lifetime increase of clot risk. So certainly something just to consider based on a case-by-case basis. For folks that have migraines, adding estrogen can sometimes worsen those migraines. I recommend starting really low and titrating very slowly with these patients to avoid worsening these headaches. The other thing to consider is avoiding injected estrogen. We think that the reason that sometimes these migraines worsen is those fluctuations in hormone levels. So if we avoid that injected estrogen, avoid those peaks and troughs, we may find that we don't have as much effect on worsening migraines. And finally, obviously, any medication, any therapy that we ever pursue does come with some risks, and it's important that our patients know about them. Again, the big one with estradiol is the increased risk of blood clot. Studies are sort of mixed on how actually increased this risk is, placing it anywhere from actually no increased risk to up to 4 times increased risk, depending on where you look. Again, a way to reduce that risk is to use a transdermal estrogen patch. Another way is that we think is likely reducing risk as well is taking estrogen sublingually if we're doing the oral, letting it dissolve underneath the tongue. With that, we're avoiding that first pass metabolism. It's kind of a gloppy mess. You have to hold it under your tongue for like 15 minutes, and it's a little bit unpleasant, but it can reduce that risk of VTE. There can be changes in blood pressure and cholesterol profile, so I would recommend continuing to screen for elevated cholesterol yearly like you would with any of your other patients. And of course, monitoring blood pressure at every visit and adjusting or adding medications as needed. Spironolactone, the big issues that we see are increased urination. It is a mild diuretic. So you can see patients that notice a lot of increased urination with this medication. A big thing is if you're using once daily dosing, don't take it before bed, take it in the morning. So hopefully you aren't making your patients be up all night using the bathroom. You can also, of course, monitor that elevated potassium, and this one can actually lower blood pressure. So again, monitoring the blood pressure at every visit. I have some patients that they could be on huge doses of spironolactone and they don't notice any difference whatsoever. I have patients that on the tiniest dose feel like it's making them super dry and lightheaded, and making their blood pressure low. So it's just a little bit, monitoring your patient, not making big jumps in dosing, and just making sure your patient is aware of the risks so they can be in touch with you and talk about how their medications are affecting them. So moving on to masculinizing therapy, our goals are to increase the level of testosterone, and the only medication involved in this for the most part is testosterone. That's it. Again, there's multiple formulations of this medication. The biggest issue that I run into with my patients is it can be quite expensive for uninsured patients, or for patients who are not using insurance to cover their medications. So that's certainly something to consider, particularly when we're thinking about what formulations we want to use for our patients. In terms of our timeline for physical changes, within the first 1 to 6 months, if you have a family history of balding and you think that might affect you, that can definitely happen. We'll notice deepening of the voice, potentially increased acne. You will notice increased and coarser facial and body hair. And again, that change in distribution of body fat into a little bit more traditionally masculine or phenotypically masculine distribution. Enlargement of the clitoris will occur, as well as cessation of menstrual cycles and increased muscle mass and strength. When starting a patient on testosterone, one of the things I really talk about is this change in distribution of body fat and increased muscle mass. It's particularly important with these patients to talk about the way that fat may distribute itself, because when we talk about that more phenotypically masculine distribution, what we're often talking about is fat around the midsection. And that fat is, of course, the fat that tends to be a little bit more hormonal in nature, meaning more likely to cause increase in cholesterol levels, more likely to cause diabetes. The flip side of that is if this patient really takes this opportunity to start, exercising, working out, they will really notice some increased muscle mass in that very traditionally masculine distribution and really see those changes that they're looking for. So definitely something I take this opportunity to discuss with my patients. So testosterone dosing, again, not here so much for the actual doses, but more to discuss the formulations. Most commonly with my patients, we do the injectable intramuscular testosterone cypionate, and that's really for purposes of affordability. Most of the time with these injections, I can get a month's supply of testosterone for my patients for about $20, plus a little bit extra for the actual injecting supplies. So definitely, in my experience, the least expensive of these options. The next most affordable is the topical testosterone gel. Usually what I use is the 1.62%. Patients certainly like avoiding injections. I've not yet met somebody who is excited about giving themselves a regular injection. There are some issues with this, specifically that the gel takes a really long time to dry, like 3 or 4 hours. And while it's wet, you do run the risk of passing it to another person if another person touches your skin where the gel is while it's still wet. So that's an important consideration with that one. The one that my patients always prefer is, oh, and I should say that using a GoodRx coupon, I have been able to find, I think at Kroger and Walmart and Food City, you can usually get a month's supply of the testosterone gel for about $60 to $65. So definitely spendy, but not, manageable for most of my patients. Finally, the patch. That is certainly kind of the one that most of my patients would really like. It's a little bit more set it and forget it. You don't have to worry about it drying. You don't have to worry about, somebody touching in some of that medication rubbing off on them. However, even with a GoodRx coupon, the cheapest I've been able to find this is $600 a month. So unless insurance is helping out with this, the testosterone patch is usually not a good option for my uninsured patients. Again, our monitoring for lab values. The big thing that we want to watch out for in these patients who are taking testosterone is elevation of hemoglobin and hematocrit, which is red blood cell count. So we certainly want to get a baseline of that before we start. Otherwise, it's just every now and then getting those hormone levels and using those to titrate our doses. And same thing with this as with our feminizing therapy. There's no evidence to support that we need to screen for cholesterol or diabetes any more frequently than we would based on preventative screening guidelines. So going again into the changes that are permanent and the changes that are temporary. Permanent changes are the deepening of the voice, as well as increasing or thickening growth of body hair and facial hair. Any potential hair loss that occurs in male pattern baldness will be permanent, as well as the increase in size of the clitoris. Changes that are temporary is the cessation of menstrual periods. Any weight changes or muscle mass changes would be temporary. Any sensation of increased energy would be temporary. Skin changes temporary. Changes in sex drive and changes of mood also temporary. So some special considerations for masculinizing therapy. A big one that we see fairly frequently is pelvic pain. This is not an uncommon symptom that we see pretty quickly after the initiation of testosterone. Of course, we always want to rule out infectious causes, but if our infectious workup is negative, you can consider atrophy. And sometimes topical lidocaine versus topical estrogen can help a great deal for these patients. Like we discussed already, the erythrocytosis or polycythemia from the elevation of red blood cell counts, just monitoring hemoglobin and hematocrit regularly. You do want to note, and I'll mention this several times, that depending on the way that your patient is in your chart in terms of their gender, or excuse me, their sex that's assigned in the chart, you may notice that the ranges of labs that are coming back are not actually appropriate for that patient. So we want to make sure that when we're using testosterone, we're using the male normal range, not using a female normal range for that patient. Some big consideration that I always discuss with my patients is contraception. While testosterone does typically stop menstrual cycles, it is not reliable contraception on its own. And it's especially important to know this because testosterone is teratogenic and can be very harmful if a pregnancy were to occur. So if this patient is having a sexual relationship with a partner who produces sperm, I do recommend that we use some form of birth control. Studies are mixed on whether avoiding estrogen and birth control is significant in these patients, whether having that exogenous estrogen would affect their testosterone therapy. But even if it doesn't affect it, most of my patients don't love the idea of when we're trying to suppress estrogen, adding exogenous estrogen for contraception. So I try to stick to our progesterone only birth control options. Nexplanon is a great option. It's a hugely effective form of birth control. It's a little device under the skin that no one knows is there, no one would ever notice, and it works great. Depot shot, since you'll be seeing your patient fairly regularly, depot shot is a good option. It's an injectable birth control that happens every 3 months. You can do oral progesterone only pills, as well as IUDs. So for when we're titrating these medications for our patient, one point that I always try to make sure that we're aware of is that as long as we aren't finding that hormones are in unsafe levels, my main goal is that my patient is pleased with the changes that they're experiencing. We use lab values as a guide, but at the end of the day, I'm treating my patient. I'm not treating a lab value. So if my patient is having a good experience with their medications, we don't necessarily need to make changes based on lab values. And again, that reference range, transgender women, their lab should be measured on a female reference range and vice versa. We want to make sure that we're using the correct ranges for our patients. So again, coming into fertility, this has been mentioned already today. There's honestly not much known about how HRT may affect fertility in our patients. Anecdotally, with testosterone, we do see that cycles usually return after the cessation of testosterone in a range of 3 to 6 months. But we can't safely just pretend like infertility isn't a risk of this medication. So we do want to have a very frank conversation with our patients about how they may want to consider fertility preserving treatment prior to initiation of their hormone therapy. I actually had a patient start treatment with me and had 1 dose of testosterone and came back and said, you know what, I think we need to wait because I need to address this fertility thing first. So it is a really important conversation to have with your patients. And again, we already talked about this, but I feel like it should be said again. Any activity that can result in pregnancy, contraception is recommended for patients that are actively on HRT. So going into some non-medication options, I feel like I do have to say that I'm definitely not a surgeon, really, really not a surgeon. And I'm certainly not an esthetician, but I do try to have a working knowledge of sort of the non-medication options that my patients may seek, so I can help advise them. So a big one that was already touched on briefly is hair removal. Um, the two sort of major kinds of hair removal that you'll hear of are laser hair removal and electrolysis. So laser hair removal is technically only approved for hair reduction, and it specifically works on pigmented hairs. The laser actually hits that pigmented hair, creates heat, goes down into the hair follicle and destroys the follicle. Treatments are every 4 to 8 weeks. They use the laser, it kind of has like a quarter-sized diameter of the area that it's treating. Treatments are usually fairly short, maybe a little bit uncomfortable, but not particularly painful. However, they are generally ineffective on light hair, red, blonde, or gray hair, which is an issue for quite a few patients, as you can imagine. Electrolysis is really a more definitive treatment that actually uses this tiny little needle-shaped probe that sends an electric current down to the hair root to destroy the follicle. It is one hair follicle at a time. There's no quarter-shaped diameter, but it can be used on all hair colors and skin types. Treatments are weekly. They last up to an hour, and my understanding is they can be fairly uncomfortable. However, this is probably the most definitive method of hair reduction or hair removal for patients. Another big concern is voice feminization. With masculinizing therapy, we do see changes in voice. However, with feminization, we do not. And many patients will seek advice on options to increase the pitch of their voice. So what pitch is related to is the actual vocal cord mass and tension. And of course, we can all sort of voluntarily increase the pitch of our voices, but this requires a lot of concentration. It's constant muscular effort, and honestly is very fatiguing. Most folks would have difficulty sort of voluntarily increasing the pitch of their voice all day, every day. There are several kinds of behavioral voice therapy that can be very effective in assisting patients with increasing the pitch of their voice. The two sort of schools of thought are flow phonation and resonant voice therapy. Both have been shown to be successful in increasing the pitch of a patient's voice. There are several surgical interventions with sort of varying success. The sort of first surgical option that was available was elongating the vocal cords. I actually wrote this down so I have to remember it. It's called a cryothyroid approximation, and it actually increases tension on the vocal folds by using sutures. It did work and was successful in elevating the voice, but it seemed that over the course of a year, the effects waned. There's also surgery to reduce the vocal fold mass and length. This is a therapy where they actually open the larynx and remove a third of the vocal folds and then suture it closed. Obviously a very invasive surgery. It did show an increase in pitch from 139 hertz to 196 hertz, but the results were fairly unreliable. And again, it is quite an invasive surgery. Finally, there's a surgery to increase tension, which actually utilizes scarring of the front of the vocal cords, which does elevate pitch, but people also find that after this procedure, their vocal range and volume may decrease, which is often a trade-off that folks aren't willing to make. Going into gender affirming surgery, we have feminized. This is of course not an exhaustive list, and I do feel the need to say again, I'm not a surgeon, but feminizing mammoplasty is breast augmentation, male chest reconstruction or mastectomy, which we'll mostly hear referred to as top surgery. There are gynecological surgeries such as hysterectomy or oophorectomy, which is removal of the uterus plus or minus the ovaries as well. Orchiectomy, which is removal of the testicles. There are facial feminization surgeries, as well as genital surgical procedures, which are vaginoplasty and phalloplasty. Those surgeries are extremely complicated, and I do not pretend to have a working knowledge of the actual procedure itself, but I did want to share a little bit about the aftercare of a vaginoplasty, just so we can appreciate sort of how much focus and intent this takes from our patients. You have to avoid any strenuous activity for 6 weeks, no swimming or biking for 3 months. For the first month post-op, sitting may be very uncomfortable. As you can see, there are lots and lots of things to consider in the aftercare. But the big thing that I wanted to talk about was dilation, which is an important part of the post-op care of these patients. This involves dilating the neovagina for 10 minutes 3 times a day for the first 3 months post-operatively. Then for the next 3 months, it typically goes down to once a day. For the 3 months after that, it's a couple of times a week, 2 to 3 times a week. And for the next 3 months after that, and usually for sort of the rest of time, it's at least once a week. And historically, that's a super important and critical part of postoperative care for that surgery. So finally, again, just because we're focusing on hormone replacement therapy, we don't want to forget that at the end of the day, we want to make sure our patients are getting good preventative health and good primary care. So one thing I did want to touch on is the physical exam of our patient. We want to make sure that this is relevant to the anatomy that's present, regardless of gender presentation. We don't want to do unnecessary physical exam either. Make sure that it's relevant to the what we're discussing at the visit at that time. And we do need to give consideration for these patients. The significant trauma that many of these patients have experienced in the healthcare system, whether that's discrimination or even physical or emotional abuse from other healthcare providers. This is something we need to really be sensitive of. The other thing is it is important, just as the physician for a patient, to be aware of what organs are currently present so that we can make sure that we're taking the best care of our patient. So something to consider is actually maintaining an organ inventory to make sure that we can successfully screen and also guide the management of specific complaints that our patients may have. I also recommend when examining a patient or discussing medical complaints that a patient may have, using gender neutral language. Depending on your patient and where they are in their treatment, using these sort of gender specific terms may be very uncomfortable or even triggering for them. So things like using the word genitals instead of vulva or vagina or penis or testicles, using internal canal instead of vagina, chest instead of breasts. These may help make your patient more comfortable in the exam room. So when it comes to cancer screenings and preventative care, the big thing that we want to remember is that if an individual has a body part or organ that meets criteria for screening, we should screen it. And if they don't, we don't need to screen it. Pretty straightforward, you might think. So breast cancer screening for transgender women. So risk is likely reduced due to there hasn't been as much overall lifetime estrogen exposure, and in many cases, no exposure or minimal exposure to progesterone. However, trans women are more likely to have what we would consider on a mammogram to be dense breasts, which is an independent risk factor for breast cancer and can increase the number of false negative mammograms that we have. So that's definitely something to consider in these patients. In terms of screening recommendations, we recommend beginning screening at age 50 and 5 to 10 years after the use of feminizing hormone therapy. So if your patient is 50, but they've only been on feminizing hormones for 2 years, you can wait a few years before you start screening them. You want to screen every 2 years. And if you do have a transgender woman who has a family history that's concerning for a BRCA mutation, you would want to refer them to genetic counseling for further evaluation. So for prostate and testicular cancer screening in trans women, for prostate cancer, most cases occur in those that start hormones after 50. It seems like the hormones are actually protective to a certain extent. For most of those patients that develop prostate cancer who began hormones after age 50, in many cases, of course, it's impossible to know, but we think that those may be tumors that actually existed prior to the initiation of hormones. And then, of course, removal of gonads and exposure to estrogen likely reduce risk of prostate cancer. We want to screen up based on guidelines for cis men, which, of course, the guidelines for cis men itself are a little bit vague. The recommendation is periodic PSA-based screening, age 55 to 69, based on shared decision making. So basically just discussing this with your patient and deciding whether or not you think screening is appropriate. It is important to note that on a trans woman who has lower testosterone levels, it may, when you get that PSA, you may want to think about reducing the upper limit by 1 and having a little bit of a lower threshold for additional evaluation for risk of prostate cancer. And then testicular cancer, we do find that the risk of this decreases with androgen suppression. And routine screening, we don't routinely screen cis men, so there's certainly no evidence or need for routinely screening trans women. One thing to think of though is if you do have a trans woman who's on a therapeutic estrogen dose plus an androgen blocker and they still have persistent testosterone elevation, you do have to worry about a potential testosterone secreting testicular cancer. You would want to evaluate with exam, laboratory testing, and even scrotal ultrasound if that seems appropriate. And now breast cancer screening in trans men. We screen based on current guidelines in trans men who have not undergone a bilateral mastectomy or who have only undergone a breast reduction. There's no really great evidence or guidelines at this point for the screening of trans men who have undergone a bilateral mastectomy. We think that the risk of cancer in residual breast tissue is really unknown. And the other issue is, of course, if we're dealing with a patient who's had a bilateral mastectomy, mammography is going to be really technically limited. So you're probably going to have to consider breast ultrasound or MRI. So really something to consider on a case-by-case basis, but certainly something to take seriously if you have a patient who thinks they've noticed a change in any potential residual tissue that they may have. Finally, cervical cancer screening in trans men. Pelvic exams can certainly be challenging for trans patients. They're often challenging for patients who aren't trans. But it's important to note that trans men are less likely to be current on their cervical cancer screenings. And we know that we have increased risk of progression from HPV to malignancy in patients who have never been screened or who have rarely been screened for cervical cancer. And we certainly want to make sure that we're taking good care and preventing cancer when we can in our patients. We do want to do what we can to improve this experience for our patients. One of the big things I always recommend for any patient, honestly, is making sure we're speaking to them before we ask them to disrobe. Nobody likes to have a conversation with their doctor when they're already naked. And also just using our good speculum techniques so that we're minimizing pain. However, I would also add that if a patient declines screening, as long as they understand the recommendation and the risk of that, I would certainly not consider that a requirement for testosterone therapy. Patients always have the opportunity to refuse cancer screenings, and as long as they understand what I recommend and the risk of refusing that therapy, that's their right to do so. So these are my last couple of slides. I know I'm getting close to running out of time, but I just wanted to kind of, as the last speaker of the day, just remind us why this matters. Obviously, you're here on a Saturday. You know that this matters so much, and this has all been mentioned earlier in the day. But 28% of transgender people report delaying care due to past discrimination. 19% have been denied care previously outright. Half of transgender people report having to teach their physicians, their providers, about their own healthcare. And of course, we all know that these statistics are significantly higher when we consider trans people of color. Primary care is really the entry point that most patients have into the healthcare system. And so we want to make sure that part of providing good primary care, whether you're actually providing HRT or not, is making sure that that we're providing a safe space for our patients. And of course, the adult transgender suicide attempt rate is 40%. So this is truly life-saving care. These are the big resources that I use in my office for treating my patients. The UCSF guidelines for primary and gender affirming care of transgender and gender non-binary people is truly the reference that I reach for the most. It's excellent. Of course, the WPATH standards of care are also excellent. And also the Fenway Institute has so many amazing educational materials, previous CMEs that are all recorded and available for free on their website. So if there's a specific topic that you're looking to learn more about, this is a great resource. This is my email address. If you have a question, want to discuss a patient, want to refer a patient, absolutely let me know. I'm more than happy to talk to you. I'm so grateful to be here in Knoxville and providing this important care. And I'm so excited to see what a community we have that's here with us today that is doing this important work. Thanks so much for having me, and I'll be available for any questions anyone may have.
Awesome. Dr. Kolarik, thank you so much. Right on time. Perfect. Thank you for all the information as well. So a couple of people shared some questions, and the first one was just, what's the difference between injected and an oral dose of estradiol?
Gotcha. So it's all the same medication. It's all estradiol. You do dose it differently. It's obviously not a 1-to-1 milligram equivalent. The biggest consideration that I would say is just that the way that the steady state of the hormone versus the peak and trough of the hormone that you're going to get with injections. Some patients prefer the injections because they feel like it kicks in a little more quickly than the oral. So, you'll find a handful of patients that even though they don't want to do the injections, they would prefer the injectable formulation because of that. But that's really the main difference. Both are completely appropriate medications.
Gotcha. Okay. All right. So the second one is a hysterectomy still recommended after 5 years of HRT? And if so, are there any longitudinal studies that have been started for the long-term effects of HRT?
Gotcha. So obviously long-term studies are limited by, the length of time that we've been providing HRT for patients. As of this moment, I don't believe that 5-year hysterectomy recommendation is still like a standard recommendation. Certainly someone correct me if I'm wrong. But I expect more longitudinal studies to be forthcoming as we have been doing this for longer, but that's kind of the big limitation there.
Okay. And then the next one that I have is, I know you mentioned briefly that some of these things are very expensive to buy, especially for uninsured patients. Do you know of any resources or any options, maybe through Cherokee or otherwise, where uninsured patients might start some of this process?
Gotcha. So for uninsured patients, certainly in terms of physician visits, Cherokee can certainly help with the actual visit. We do offer sliding scale for patients. So in terms of the actual doctor's visit, we can definitely help out with that. We do have a pharmacy in the building for Cherokee that does make the cost a little bit less for some medications, not across the board, but for some medications we can get a little better pricing. The good is for feminizing therapy, for oral estradiol and spironolactone, those medications are dirt cheap, whether or not you have insurance or not. So that's typically not that big of an issue. The testosterone tends to be the biggest issue. And so just, using GoodRx coupons, and again, just because that injectable formulation does seem to be a little bit less expensive.
Great, thank you. Do you think you could speak briefly on PrEP or PEP?
Yeah, absolutely. So for PrEP and PEP, of course, the same guidelines exist for trans folks as would for cis folks. Both PrEP and PEP, but particularly talking about PrEP, is an incredible medication that, if there's someone who is at a higher risk for acquiring HIV, whether that's because they have an HIV positive partner or any other reason, there's no indication that PrEP would have any, you can certainly do that with any medications for HRT.
All right, thanks. The next one is, what's the process of getting the syringes like for injectable hormones? This person has heard that trans folks, that knowing the right size has been a challenge, as well as discrimination from pharmacists based on that. Could you speak a little bit to that?
Gotcha. So I prescribe the syringes when I prescribe the testosterone. So theoretically, they should be at the pharmacy with your medication. I do personally, I feel strongly that I need to understand how to, and apparently bulk from the internet also works well. But I do try to personally teach my patient how to do the injections, just because I know that there may be some stress at the pharmacy in asking for teaching from the pharmacist, which I think is where a lot of times we rely on our pharmacists to teach how to use the medication. So I make sure that that I'm teaching that myself. And if the patient feels confident asking the pharmacist, then they get it twice, and that's twice as good. I also, while I don't recommend regularly coming to my office to get your injection, for the first few times, I'm certainly happy to schedule you for a nurse visit and have my nurse do the injection with you, just so that you can feel comfortable with it, with drawing up the medication, with where to inject, with how to clean the skin and all that good stuff. So I don't think that's something that we could do for, my nurse, who is amazing, has offered like, oh, I don't mind if they come in every time and get their injection here. But at the end of the day, I don't think we have the resources for that. So, but we can certainly help with teaching the first few times until you feel comfortable with the injection.
Can I add something here and then ask a question related? Just because I've been hearing that there are a couple of other options for syringes. So for example, student health at UT, if you are a UT student, I believe that blocking on her name, Becky Morgan, and her colleague Maggie Farley, who used to be at Planned Parenthood, I think will also provide HRT as well as syringes, as well as teach you how to do this. I think that Choice Health, which is affiliated with Positively Living, is now providing some syringes as well. And I'm not sure what they do in terms of, I'm wondering if it's a way to get kind of patients in for their services, or if you don't have to be a patient, but I just know that's another place. And Corey said, you don't need to be a student to use the UT pharmacy, and it's the cheapest tea in town, and they carry the 10 milliliter bottle. So that's great information for people. But while we're on this, I wondered, Dr. Kolarik, if you could just talk about Wellspring, because I know that's a relatively new service that Cherokee has. You're really trying to get in touch with the community. If you can just talk about the services you all provide, that'd be great.
Yeah, absolutely. So first of all, that's great information about the UT pharmacy. I had no idea that the general public could use that pharmacy, and I'm going to call them on Monday and get all that information. And actually, Dr. Morgan trained me when I was in residency. She is excellent, and I am always grateful for the education that she provided me and how to provide good gender affirming care. So Wellspring at Cherokee is a division of our general services that focuses on care of marginalized groups. So the big things that are provided, of course, it's with coordination from primary care, but it includes, and of course, behavioral health is with all our integrated care at Cherokee. But it provides PrEP and PEP. We have walk-in appointments and multiple opportunities for patients who may require those services. Medical assisted treatment of drug and alcohol use. We have an amazing team that does a great job at helping with addiction medicine and provides an excellent service for those patients. And then of course now LGBT care and providing HRT is kind of the newest extension of Wellspring. And it's a super exciting team to be a part of.
And do you know many other physicians who are openly providing services? I always hear that there are physicians who can do this, but that they don't like to advertise that because of the stigma that still exists in the community. And I'm curious if what your experience has been coming here and seeing how open providers are to provide these services.
I think in general, a lot of primary care docs just don't, what they'll tell you is they don't feel comfortable with it. I think there's certainly a desire to provide this, but they don't kind of know how to get the training. So that's how I sort of consider a big goal of mine is to empower more primary care docs to offer this service. Obviously at UT, Dr. Morgan is doing a great job. There is over at University Family Physicians, which is the resident clinic over at UT Hospital. There are a couple of docs there that provide it. I have heard there is one doc with Summit who does. I am honestly not sure of their name, but of course, being with Summit, they, insurance is a bigger barrier for that office. And then, of course, for our younger patients, the Peds Endocrinology office here in Knoxville, I believe there are 4 physicians with that practice, and 3 of them are doing puberty suppression, and patients get excellent care there.
Oh, okay. This person wants to know, am I correct in my understanding that you can offer significantly low cost of PrEP and PEP That's been an issue for a number of clients.
Yes. So we have an excellent prep navigator at Cherokee who makes magic happen. I do not claim to have that expertise, but I know that my patients do not have problems with accessing these medications.
And so for this last 15 minutes, let's look at some questions here. I believe, Corey, you wanted to say something about your experiences as a trans person without dysphoria. Would you mind sharing a little bit of that?
Absolutely. Yeah. Just that somebody had asked Samuel about, how you could be trans without gender dysphoria. And I was like, oh, me. Yeah. And I, struggled for a long time to think I was trans because everybody was, the story that I felt like was most common was born in the wrong body, or I was always this, or I was always that. And for me, like, I was a girl. I liked being a girl. I liked wearing dresses as long as they had pockets for my Matchbox cars and Lego. I would wear a tutu while I dribbled the basketball down the street. I was raised by a second wave feminist and pretty solidly, free to be you and me. So gender was never something I wasn't allowed to explore. I was one of the first female wrestlers in the state of Michigan. But I also did color guard and marching band. So yeah, I think for me, I used to call myself like diet trans or trans light, because I thought like I couldn't actually be trans because originally I didn't want surgery. I didn't want hormones. And I didn't have dysphoria. So that was a long process. But yeah, I actually had more dysphoria, I think, after I started transitioning, because I was like, well, that's weird. But for the most part, yeah, no dysphoria, and pretty dang trans, even before I transitioned.
Someone is asking if there are any current peer support training here in Knoxville, or will this opportunity open up once the Pride Center is open? I am not familiar with any peer support training that's available, but I wondered if any of our other panelists were aware of anything.
No.
Okay. So I think there's an opportunity, right? There's a need there. And that may be something that perhaps the Knox Pride Center will do, or if there is a second Pride Community Center could do. That is certainly something that the UT Site Clinic, which I am the director of, we could certainly look to format. So if people are interested in something like that, please just email me and I'll gather materials, or you can put something in the evaluations that we send you, and we can look at what we can create going forward. Someone asked in the chat, not directly related to the current session, but just out of general curiosity, I'm a radiologist. I'm curious to hear from the panelists about their interactions with routine imaging and screening care or recommendations. So for example, have you had any difficulty obtaining mammographies, abdominal or transvaginal ultrasounds, XR bone density screenings for osteoporosis? Does any panelists want to share any experiences that they may have had? Go ahead, Sarah.
I actually went through the health department to get my mammogram, and they were just really, really wonderful with me. And they had several locations that I could choose from. They did not charge me. It was totally free. And then when they felt like the breast tissue was too thick, they actually had me come back, and the health department helped me with that as well. My first experience was at one of the hospitals, and I didn't end up going there for it because they were asking me questions across the lobby, quite frankly, and trying in very loud about it. And so I left there. But the one I went to was absolutely amazing, and I plan to go back.
Well, and what I was going to share was, having, identifying male, my primary care, I had to educate that person, although she is phenomenal, and I really do appreciate her. She learned to manage my hormones and all this good stuff, and took it upon herself to get educated. Really appreciated that. But I needed a referral for some gynecological care. And bless her, she sent me to Women's Care Group, who has a great reputation, but that's also like it gave me a little bit of like, I don't want to call the women's care group back, you know, and I know that's something so dumb, you know, but that would be something, you know, just sending a guy to the women's care group felt funny to me, even though they have a great reputation, nothing against them. And that might be just my own dysphoria about showing up at a women's care group for, you know, gynecological care. So it's my 2 cents.
Well, actually, I actually went to the women's care group to get my chest looked at before I had my surgery. The lady that helped me was asking me a lot of questions about being transgender and how she could help and like how I can help her understand.
Mm.
That was actually one of the most positive experience I've had, like helping, you know, but I do agree. It was weird going to a women's care group and like walking in and like, hi, like, hello. But she was actually really sweet and really understanding. Got my chest looked at and she was very like consensual. She was like, hey, I'm gonna let you know, I'm gonna be like looking at your chest, like, you know, just kind of help me, you know, be comfortable and why I was there and stuff. But other than that, that was probably one of the most recent like positive experiences, and that was in like December, before my surgery. But I do like, it was really weird walking in there and like talking to them about it, but yeah.
Great, thank you both. Samuel, I was wondering, because I know that you had to go through a couple of your slides quickly. My guess is that there are people who would be interested in hearing a little bit more about kind of your letter writing process, and if you want to just say a few minutes about what you do and how you do that before we move on to some other questions. I'm going to make sure you unmute there.
Yeah, and so probably what I think would be the most helpful thing is like, it's learning how to write enough that says this person, you know, to meet the guidelines and not over either, because not, you know, we want to make sure that we're not over disclosing everything, especially because that a lot of times, you know, if there is a mental health concern, that can be become an obstacle, you know. But if the mental health concern is well documented, or if the mental health concern is judged, you know, in your clinical opinion to be impacted significantly by gender dysphoria, I put that in there.
Mm-hmm.
You know, if I have a client that has been recently suicidal, that is at their baseline, which exists. I mean, a lot of my adolescents that, you know, kind of passive suicidality is their baseline existence at this point. I'll put it in there that, you know, for like a hormone letter for adolescents, like that this is just, you know, treatment for gender dysphoria is likely to improve their mental health symptoms based on the research. And so I will put that in there. I let the clients read the letters so that they know what's going in there. And so it's a, you know, it's a consensual process there as well. I wonder if there's any like specific questions about, oh, well, the part about the 12 continuous months of living as a woman or living as a man or living as some other gender, right? Like I said in the presentation, like if the person has indicated to me that they're out, they are whatever gender they're telling me, I don't care whether or not they're going, you know, if they're wearing makeup all the time or shaving anything, or, you know, it's that it's their lived experience that's important, that it's congruent with how they feel on the inside. And so as far as like a gatekeeper kind of thing, like, you know, not using that as a tool to, you know, prevent the client from proceeding with care because it wasn't safe for them to go to work dressed in a skirt. You know what I'm saying? And did anyone have any specific questions regarding the letter?
I'm not seeing anything pop up, but in case they do, I'll keep an eye on it. Somebody did ask if they could use your letter template.
Knock yourself out.
Great. And I will also put a pitch in for Colt Kalmeyer. I think that's how he pronounces it. He's got a great training called Gender Asset. And if you just Google Gender Asset, it's a CE. It's not cheap, but it's a really great training for how to do these. He also gets into great detail about the surgical piece, about the advocacy piece. So for anyone who's looking to provide services like this for, in particular, mental health providers, I strongly recommend that training. It's really valuable. Somebody posted, this was partly touched on in the first session, but I'd love to hear more. For those who pursued medical transition, what were your largest systemic challenges? Was it employer policies and insurance, finances, ID change requirements? Were there certain policies, programs, opportunities that helped the most that you wish could be adopted elsewhere, or things that you heard about in other locations or states that you would like to see?
I was actually really surprised because I've had a good result with somebody getting their ID changed or their birth certificate changed in Illinois, and they were actually are using the N for non-gender. So that was fantastic. My personal concern is simply the cost of gender affirming surgeries. It is prohibitive for a lot of us, and you know, the recovery for just some of the surgeries can be quite extensive, and you have to be able to afford to live during that time. And you know, for those of us who are career people, you know, it's something that is quite difficult.
Anybody else have any other comments regarding policies or systemic issues?
Well, you know, I had an issue at the Social Security office, which I'm wondering how that's going to change, or if it will change now that we've had an administrative change, you know, with the presidency. But when I went, you know, Trump was president, and I had a very negative experience at my Social Security office. Like, I thought I might be arrested. So, because the people were very rude to me, and I was also not backing down to them. I wasn't rude, but you know, it was a very negative experience with, you know, them having to have this very precise thing, and them not being really well versed in what was acceptable, because I had it printed out. Like, before I went, I was kind of armed with, I have the appropriate thing, and they were just focused on some really, I mean, they were just not educated, you know. And he tried to be comforting, telling me about changing the gender marker when he worked at Louisiana for some trans woman that had walked in there, and you know, and he made it I mean, like, kind of a transphobic remark about a transgender person trying to get their gender changed before, you know. So from the get-go, that was a very negative experience, just with the people not being educated. But like at the DMV, not a problem at all. Yeah. So, and the court system was easy to work with.
Sarah?
Yeah, I'm assuming that you must have gone prior to COVID. I
Yes.
did mine through the mail, and I called them, and the person who helped me was extremely affirming and helpful. And they just told me exactly what I needed to do. I did it. Next thing I knew, I had my Social Security card. It was not even a concern.
Interesting.
You paved the way for us.
I don't know. I will tell you this. So during COVID, there was an instance where I did need to use the Social Security office, and I did it by mail. I have some adopted children, and we were like trying to get all their documents squared away, right? For insurance cards. And I sent all my stuff, because you have to send them all originals. So I had, you know, my adoption order, which was in my old name, my ID, which is in my name, my court order for my name change. They sent it back to me and said, we don't know what you want to do, even though I'd put a letter in there. Right?
Oh my word.
They were, yeah, it was really ugly. But I called, and whoever I got on the phone was a local person, and that person was great and scheduled me like an appointment, even though that was kind of against their policy for COVID. So that was the one good experience I had, was after. But like, for weeks, I didn't have my ID because it was at the Social Security office, you know. And so I think it's hit or miss. Like, I mean, like, if you get a transphobic individual, I think that it can still be messy.
Just like that, I feel like that is a really good example of like the issue. Like, one of the issues is that it's totally arbitrary and it's crazy making. Feels like you could go to like the Walgreens on Broadway and get one pharmacy, and they won't give you what you need, and you could go the next day and get a different pharmacist, and it's totally fine, right? I got a name change without even going to a court because of weird things that happen all in my favor. Just all happens to be who you get, but it makes it sometimes even more challenging.
And so I really want to thank our panelists and our speakers very much for taking the time to educate us about this, and for all of you who have attended. I hope it's been useful. I hope it's been enlightening. And it was great talking to you all, and nice meeting everybody.